Hello everyone, and welcome to our module on the anatomy of the liver, gallbladder, and pancreas. This slide shows a drawing of the major anatomical structures related to the liver, gallbladder, and the pancreas. Bile, as you may know, is formed in the liver and then it drains into the gallbladder. There is a right hepatic duct and a left hepatic duct which drain bile into the gallbladder through the cystic duct, which is shown here. When the gallbladder contracts, it can push bile into the common bile duct from which it can drain into the duodenum. The pancreas also has a duct which merges with the common bile duct and then empties pancreatic secretions and bile into the duodenum via the ampulla of Vater. In order to get through the ampulla of Vater, you have to pass through a small muscle called the sphincter of Oddi. We'll talk about all these things in the next few slides. Let's start by talking about the ampulla of Vater. An ampulla is a Roman flask. This is a picture of one shown on the screen. You'll notice that it's wide in the middle and it narrows towards the top. So the ampulla of Vater is where the biliary and pancreatic ducts merge, as I showed you on the last slide. And because they merge and then the ducts begin to narrow, it reminded people of the shape of an ampulla, and hence the ampulla of Vater was named. When enzymes and bile flow through the ampulla of Vater, they enter the duodenum through a hole called the major duodenal papilla. This is where bile and pancreatic enzymes enter the duodenum. It's also the halfway point along the second part of the duodenum, and this is the anatomic transition from the embryologic foregut to the embryologic midgut. And I talk about both of these structures in detail in the video on GI embryology. But what I want to mention here is that because the duodenal papilla represents the transition from one embryologic structure to another, there is a different blood supply before and after the duodenal papilla. Before the papilla, the blood supply to the duodenum comes from the celiac trunk. After the duodenal papilla, the blood supply comes from the superior mesenteric artery, and that's because the blood supply derived from different embryologic structures. The major duodenal papilla is that hole that the ampulla of Vater empties into the duodenum. You can see it on this picture here. It's a little bump in the wall of the duodenum. You can also see it when you do an endoscopy and put a camera into a patient's small intestine. The sphincter of Oddi is a circular muscular layer. It's smooth muscle that surrounds the major duodenal papilla, and it controls the flow of bile and pancreatic enzymes. When the sphincter of Oddi relaxes, bile and pancreatic enzymes can flow into the duodenum. When it constricts, they cannot flow, and it constricts to prevent reflux of contents in the duodenum back into the bile ducts and the pancreatic ducts. There is a clinical syndrome that can occur when the sphincter of Oddi becomes dysfunctional. This happens when the sphincter of Oddi narrows. This can happen after someone's had a bout of pancreatitis or gallstone disease. The inflammation can result in a narrowing of the sphincter of Oddi. Patients who have this condition can develop biliary symptoms. They can get episodes of right upper quadrant pain. Sometimes they will have abnormal liver function tests or even hyperbilirubinemia. They also sometimes get pancreatic symptoms such as recurrent pancreatitis, and both of these are the results of poor flow of substances out of the biliary tree and the pancreas. There are some therapies that are sometimes employed for people who have sphincter of Oddi dysfunction. Sometimes smooth muscle relaxants are administered, like calcium channel blockers or nitrates, and sometimes via an endoscopic procedure you can do a small sphincterotomy and open up the sphincter of Oddi so that it works better. When you do surgical rotations, you should be aware of a phenomena called sphincter of Oddi spasm. There are some very old and relatively weak data that suggest that opioids like morphine can cause smooth muscle contraction and potentially spasm the sphincter of Oddi. For this reason, when you do surgical rotations and patients have pancreatitis, the drug of choice is meperidine, which is Demerol, because it is not believed to cause sphincter of Oddi spasm. Now, in reality, there are no strong clinical data that morphine leads to worse outcomes than meperidine in pancreatitis, but nevertheless, on many medical services and especially on the surgical services, you will often see Demerol used, and this is sort of a traditional thing because for years it was believed that opioids like morphine could cause sphincter of Oddi spasm. Now let's talk about the anatomy of the liver. If you take a section of liver tissue and look at it under the microscope, you will see that it is made up of thousands and thousands of structures called lobules. This is a picture of a liver lobule on the screen here. And as you may know, the job of the liver is to perform metabolism of substances in the blood. So the blood enters through one of these structures here, which is called a portal triad, and then the blood percolates through the hepatocytes and it exits through this structure here, which is called a central vein, which connects to the hepatic vein. And by going through the liver like this, all the hepatocytes are able to conduct metabolism on the substances in the blood. Here's a drawing to make this point more clear. If you take a section of the liver and look at it under the microscope, you will see lobules as shown in this drawing here. At the center of the lobule is a structure called a central vein, which connects to an interlobular vein and goes to the hepatic vein to drain blood away from the liver. Blood enters the liver through one of these portal triads over here. The portal veins carry blood coming from the intestines. The portal arterioles carry arterial blood, and then there's a bile duct as well. So there are 3 channels in the portal triad. That's why it's called a triad. One of the channels is the portal vein, one is an artery, and one is a bile duct. So what this means is that liver lobules have blood coming in from 2 different places. Most of the blood to the liver lobules comes in via the portal veins. This is deoxygenated blood coming from the GI tract. There's also some blood that comes in via the hepatic artery. This is obviously oxygenated blood. This represents about 20% of the blood flow to the liver. There's one drainage vessel for all the blood from the liver, and that is the central vein, which connects to the hepatic veins and can carry processed blood away from the liver. And then finally, there is a bile duct found in each liver lobule. In this picture, I've zoomed in on one of those portal triads. You can see that there is a vein here. That's the larger vascular structure. There's a smaller structure, which is a bile duct. And then there's an artery here, which is surrounded by a muscular wall. These are the 3 structures found in portal triads in each liver lobule. As blood travels from the portal vein to the central vein, it crosses hepatocytes, which are divided up into 3 zones. The first zone is closest to the portal triad. The third zone is closest to the central vein. And the second zone is in the middle. And as we will see, different pathological processes have their effects differently on the 3 zones. Here's a drawing just to make the liver zones more clear. So we have blood entering the liver zones either via the hepatic artery shown here or the portal vein shown here. Blood then moves through the 3 zones, zone 1, zone 2, and zone 3, and then it finds a central vein which ultimately connects to the hepatic vein, as I've shown here in my drawing. The first zone is called the periportal zone, the last zone is called the central lobular zone, and the one in the middle is appropriately called the mid-zone. At the same time, notice that we have bile flowing in the opposite direction, so bile flows away from central veins towards the portal triads, at which point it enters the bile duct. In the liver pathology modules, I'll talk about how some diseases affect one liver zone more than another, and they like you to know this stuff for step 1. So zone 1 is the zone right next to the portal blood. This is the zone that is affected first by viral hepatitis. Hepatitis A and E are both fecal-orally transmitted, so it makes sense that the portal blood coming from the intestines would infect this zone first. Other hepatitis viruses also affect this zone first. Zone 3 is the zone that's furthest away from the portal blood. It's next to the central vein. It's called the central lobular zone. This is the most vulnerable to ischemia because it's the furthest away from the hepatic artery and the blood supply. This is also where fat accumulation begins in alcoholic liver disease. Alcoholic liver disease prominently affects zone 3 of the liver. This is also where a high concentration of P450 enzymes are found inside of hepatocytes. I'll finish this module by discussing the anatomy of the pancreas. The pancreas looks like this drawing on the screen here. This portion is called the tail, this is the body, and this portion here is called the head. Sometimes the head is talked about as having a process here that sticks out of the bottom, and this is called the uncinate process of the pancreas. Pancreatic secretions flow through the pancreatic duct and out into the duodenum, as we have discussed. There is an alternative pathway by which pancreatic secretions can get into the duodenum without going through the ampulla vater and the major duodenal papilla, and that is this very small duct here called the accessory pancreatic duct that drains directly into the duodenum without connecting up with the common bile duct. The pancreas has unusual embryology within the GI tract because it forms from 2 buds off the foregut instead of 1. Most structures like the gallbladder and the stomach are a single bud off the foregut, but for the pancreas there are 2 buds. One is ventral and one is dorsal. Ventral means towards the front of the fetus, dorsal means towards the back, and this is shown in this picture here. You've got a bud coming off the foregut going in this direction towards the gallbladder and another bud going in this direction towards the back of the foregut. And these 2 buds are going to eventually fuse to form the pancreas. The ventral bud forms the head of the pancreas and the uncinate process. It also forms the main pancreatic duct. The dorsal bud in the back forms the majority of the pancreas. It forms the body, the tail, and the accessory duct. The pancreas is a retroperitoneal organ, but it is called secondarily retroperitoneal. That's because it initially forms covered in peritoneum as an intraperitoneal organ, but then it migrates and fuses with the posterior wall to become retroperitoneal. If you look at this CAT scan on the screen here, you can always orient yourself by finding the vertebral body and then finding the aorta slightly to the left of that vertebral body. When you're at the level of the kidneys, as shown here, you will see this snake-like thing here, and that is the pancreas, and you should be able to identify that on a CAT scan. It's very helpful for your boards. There is a congenital anomaly of the pancreas called annular pancreas that occurs when the ventral bud wraps the duodenum and causes a bowel obstruction. So the ventral bud that I showed you a few slides ago is initially composed of two separate pieces of tissue that will fuse, but if they don't fuse properly and they surround the duodenum, you can develop a ring of pancreatic tissue that surrounds the duodenum, and this can result in a bowel obstruction. If we go back to this picture here, imagine if this ventral bud from the foregut wraps around the duodenum in this way and also in that way and forms a ring of pancreatic tissue that can potentially constrict the duodenum and lead to a bowel obstruction. This would present as distension and abdominal pain typical of a small bowel obstruction, but at surgery, a ring of pancreatic tissue would be identified surrounding the duodenum, and that would tell you that you're dealing with an annular pancreas. Another embryologic anomaly of the pancreas is called pancreas divisum. This occurs when the dorsal and ventral ducts do not fuse, so that the pancreas drains via two separate ducts. That smaller accessory duct I showed you before fuses with the dorsal duct and drains a majority of the pancreas. I'll show you a picture of that in a second. And a second ventral duct persists and drains the remainder of the pancreas. This is often an asymptomatic condition that's discovered incidentally when someone has a workup for abdominal pain. Occasionally, it can result in pancreatitis. If we go back to this picture here, you can see that under normal conditions, this main duct drains the pancreas, and then there's a very small accessory duct right here that goes directly into the duodenum. What happens in pancreatic divisum is that there is no connection right here. So the head of the pancreas is drained by a ventral duct that goes straight into the common bile duct, and then the majority of the pancreas drains through this dorsal duct here, which will go into the accessory pancreatic duct and drain straight into the duodenum. And that concludes our module on liver, gallbladder, and pancreas anatomy.